And I turn it over to you, Dr. Drake, and thank you again for joining us.
Good afternoon, everybody. I guess you can hear me. Joel, you can hear me, correct? Great. My name's John Drake. I see some names on the screen I'm familiar with. Hello, Jim and Cheryl, Dave. Thanks for joining us. I'm in my 24th year here in Fort Wayne, having come out of the Navy in 1997 to practice medicine here initially with Fort Wayne Northeast OBGYN. And then joining Parkview Physicians Group in 2009 with my group. I have extensive experience with the Tony Robbins group, which is a lot about enjoying life and whatnot and coaching. And I'm trained as a coach through a company in California. But I wanted to talk today about physician burnout and suicide. So it's always, I think it's great to bring up, not just somebody else's story, but your own. And I'll start with my own story. Going through the last 11, 12 years of medicine was a huge change for my group. We went from private ownership to hospital ownership. And as all of you know who've gone through that, there is quite a bit of change. There's benefits and challenges at times. And it took a toll on me. I got to the point where in my career, I didn't want to go to work. I didn't want to deal with patients. I didn't have tolerance for anything. And I was at one of our major PVG quarterly meetings, and I picked up a book by Dyke Drummond called Stop Physician Burnout. And I read through that book, and that book's talking to me. They were talking about why I felt the way I felt. And since that time, I took on that study of physician burnout and brought that into my own coaching efforts as well. So I wanted to talk about that. The second part is to talk about when things go truly wrong. So let's talk about what physician burnout really is. About 40 to 45% of all physicians practicing exhibit at least one symptom of burnout. That's a huge number of doctors that are experiencing this problem. And the last year with the pandemic has been truly even more burning, especially because of the problems with the COVID and lots of people passing away due to a viral illness that we didn't know what to do with. But by definition, burnout is an erosion of the soul caused by deterioration of one's values, dignity, spirit, and will. That's a big definition, and we're going to talk more about it. But that's a common definition for burnout. On the other hand, stress is a normal, ever-present situation that we all deal with, and stress you can't have life without stress because nobody lives in heaven yet. Nobody's life is perfect. There's always something going on. But stress is something that you can recover from. Stress happens when life events occur contrary to your certainty. And stress is something you can recover from. So if you have a stressful week, takes a lot out of you, whether it's a lot of patients or it's night work or whatever, you can recover from that stress by going home and taking it easy, or going on vacation, or going out and doing something else. You get away from the place that causes that stress and you can recover from that. According to Tony Robbins, stress is actually something that we need of his what he calls the 6 human needs. Uncertainty is our need to not know what's coming around the corner so that we have some anticipation of something different. So if we didn't have any stress, what would we would basically not moving, everything would always be the same and we'd be bored to death. So Stress is a good thing, but stress is something that you can recover from. On the other hand, burnout is defined by psychiatrists as what they say is a job-related dysphoria in an individual without major psychopathology. In other words, it's not that you're anxious, it's not that you're depressed, you don't have any of these psychiatric disorders, it's just job-related in itself. And burnout occurs when you can no longer recover from that stress. Case in point, everybody looks forward to their vacations, can't wait to get out of the office, can't wait to get out of the patients, get away from the hospital, whatever it is. You can go on a vacation, whether that's a 3-day vacation, a week or 2 weeks, but when you come home, you walk back into that office and go, I don't want to be here. And that happens so often. And last year, I took 2 weeks off, which is not common for me to do. I went to Puerto Rico, and I was on the beach, and I had a great time, and I was off work for 12 days. And when I came home, I still had that burnout. It was still prevalent. And I had to, and it was obvious, relaxation does not make burnout go away. Now, as physicians, we are trained to solve problems. I mean, that's what we do. You know, patient comes in, has an issue. We're the scientists, we're the problem solvers that work with people and try to figure out what we can do to help them feel better, whether that's a pain problem or a medical problem or it's diabetes or something. We solve problems, but we're not taught about burnout, because burnout is a dilemma. Dilemma is something that you cannot fix by trying to solve it as a problem. Constellation of symptoms that we see with burnout include exhaustion, which won't go away, cynicism, you know, the way you feel about your patients or about the office or your staff. You know, it's not somewhere you don't want to go there anymore, because, you know, you're always going to have to deal with something and you blame it on your patients or your staff or the hospital or whatever it is. You lose that desire to deal and take care of your patients. And when you get that way, you're not looking for an 8 or 9 hour day in the office. It's like, you know, I'll only do this much and I'm going to get out of here. I'm going to take lunch. This is a term that doesn't go well with physicians, because what are doctors? We're problem solvers. And it doesn't everybody say, well, doctor, heal thyself? You know, that means you should be able to be resourceful and resilient enough to get through this. But that's not what we're taught. So we need to change that conversation. When you look at the percentage of physicians in burnout, highest number of percentage of physicians within their specialty in burnout is urology, 54%. And when I talk to my urologist friends here and I hear that, you know, they work all weekend, they do, you know, 20 or 30 consults, and they're doing all this work. I mean, that is I would think of that as a high burnout practice, and God love them, but they have the highest rate. Neurology as follows, and nephrology, diabetes, endocrinology. I mean, these are all about that 40 to 50% burnout rate. So what's causing this? Well, the practice of medicine causes it, because what is medicine? Medicine is, you know, we think of it as a 24/7 job. I mean, we're taught in medical school how to deal with all those problems, and we go through residency and we learn our specialties. The practice of medicine is draining, because this is not an assembly line. It's not like you hit the assembly line at 9 a.m. and at 5 p.m. and it's over and there's nothing else to do. There's a tremendous amount of work that we do other than just what we do in the office, whether that's charting or whether that's going to meetings and being part of this and part of that. The practice of medicine in itself is exhausting. And many people do well with it, and that is great. We all thought we had an idea what we were getting into when we got into medicine. We just thought we were going to be altruistic healers and all this other stuff. But medicine is EMR, medicine is organizations, medicine is calls and on call. So that itself is a recipe for burnout. And your specific job. I mean, you know, people just take, for example, the intensivists who are taking care of COVID patients, and seeing COVID patients not survive by, you know, especially in New York, by the thousands. I mean, that is a soul-sucking event to lose so much. Or whether it's that you have your office, and if you're an obstetrician like me, you run off and you stress about getting to that delivery in time and getting that baby out safely and making sure Mrs. Jones, everything goes right. Or whether you're taking care of chronically ill people, it all has a draining effect on us. And besides the practice of medicine, we have life beyond the office. We have our families. I'm sure a lot of people get the same text that I get every late afternoon from my wife, and it's like, when are you coming home? Well, you know, you work till 5 and I'll be home by 5:30. Well, my spouse wants me home. My kids want me home, especially when they were younger. I mean, we have children, we have events, we have neighbors, you know, we have friends, we have family. And trying to fix that life beyond the office and mix that with medicine is very challenging. I'm sure many people have been out at dinner and you get a text or a phone call and, you know, so is happening. And your spouse looks at you and goes, really? I get that. My wife wants her attention when I'm with her. Another problem that is a cause is what our medical education taught us. Now, we worked really hard in undergraduate school to make the grades to get into med school. And then we went through all those all-nighters studying and getting through medical school and learning multiple subjects. I mean, it is a labor intensive event to learn what we have to in medical school. And then we go on to residency, and then we do that for 3, 4, even 6 more years. And what do we get taught to do that? I mean, we become workaholics in this. I mean, a guy who works at a tire factory in Ohio, when he's done, when the bell rings or the whistle blows at 5 o'clock, he's gone. He's done until the next day at 9 a.m. How many people finish office at 5 o'clock and then say, I'm out of here? Don't take any charts with them. Don't do any charting at home. There's always something. And if you're a private practice owner, you know, you own that thing 24/7. So we are trained to be workaholics. We're also put on pedestals. You know, when your patient says, oh my gosh, you're the only one who could do this for me, or thank you so much, you know, you're my hero, and doctors are going to save the world, and doctors are going to do this. We're just human beings. I mean, we're just human beings. And when I talk to my patients, I always tell them, don't put me on that pedestal, because I'm a human being just like you, but our society has us put on pedestals as if we're superheroes. We're supposed to be emotion free. You know, you lose a patient, I lose a baby, or the patient doesn't survive, or you know, so and so, you know, you're doing everything you can for them, and they have a heart attack or they die or anything, and we're supposed to be locked up, emotion free. We're the ones that are the level state, even though that patient was close to us, or we really enjoyed that patient, they were a good friend. We're supposed to be the Lone Ranger. Hey, you're out there, you're it for the night. You got the place, you got the hospital, you know, you got to do everything. And we're trained that, you know, that you may, if you don't know what you're doing, somebody may lose their life, or you may lose a baby, or some procedure that has to be done isn't done. So we're taught is, don't rely on anybody else. It's just you, and you're it. And finally, we're taught to be perfectionists. I mean, really, isn't that what our patients expect? They expect us to do it right every time, all the time. And what happens when it isn't perfect? Well, if you have an outcome that's not what you expected, not what they expected, You might hear from an attorney about it. So people expect us to be perfect, non-human people that take care of them, but we're not. We're really just human beings. Main symptoms of burnout: exhaustion, and as I had talked about, fatigue that you just can't get over. You can't. That weekend, I take 3-day weekends, and that doesn't mean my burnout would be gone. I have to do something different. So exhaustion is just something you can't get past. And then you get this depersonalization where you just start feeling it's not that patient that you're trying to connect with and let them know that you care about them. You get into this compassion fatigue where each patient is like, okay, how many do I have to do today? And oh my gosh, that person's coming in. That one's such a challenging patient. Or, that patient is the reason I feel this way. That patient ruined my day. They didn't really ruin your day. You allowed them to get into your head and do that. And finally, you get into this lack of efficacy. It's just many diabetics are always going to be diabetics. It's one of the problems. Or some people with obesity are always going to be obese, that no matter what we do. Or, how many smokers have we counseled about not smoking and, they're still smoking and, they're at high risk for lung disease or lung cancer. So we get into the point where, why am I doing this? What's the point? And what's the use of this? That's not the feeling you had when you worked so hard to get into medical school. You were like, you wanted to be altruistic, you wanted to save the world, you wanted to help people feel better. But sometimes you get, not all patients really want to be cured. They just want you to care about them or make them feel better for the moment. Men and women experience these in a different order. Men, it's really depersonalization first, and then the exhaustion, and then the lack of efficacy. For women, it's in the order of that 1, 2, and 3. As far as the pathophysiology of burnout goes, Dyke Drummond, who has the website, the Happy MD, talks about 3 energy bank accounts. These are the physical, the emotional, and the spiritual. If you look at my slide here, which I did take from his book, the white area is where you have energy left. And the top where the titles are is full. E is empty. Below E is below empty. And this is not like your car. When you get below empty, your car is going to stop. But physicians don't stop at E. They keep going and they keep burning that oil to where the point you get to over time is where you're actually operating at a deficit. You don't have anything left, but as doctors, you're not allowed to say, I'm tired or I can't do that. No, there's expectation that you're going to continue to go. So, and that's why we get into that problem. These energy accounts get depleted, and when they're depleted, it's over. There's nothing else you've got left, and we're not the ever-ready battery or the ever-ready bunny. We can't do that. We can't just sit down and recharge, take a rest, because it doesn't go away that way. A little bit more description on the energy accounts, the physical being inadequate rest, not enough hydration, not eating, and not mental rest. Some days are just so challenging, you really do need that rest. You burn a lot of calories thinking hard all the time. And if you don't get enough rest, then you're going to burn your body out. So what I do to manage this, I control my working hours. I have a certain start time and I have a certain stop time. And when I go home, I'm done. Unless there's a reason I'm on call or something, I go home. I don't do charting at home. How many physicians work hard during the day, race around, get all those patients seen, whatever, your office thinks you should be seeing, and then go home and work 2 hours on charts. I was sitting at one of the community hospitals when I was taking call there one Sunday, waiting for a baby to deliver, and in comes one of the family doctors that works out in Columbia City. And I know why I'm there is because I'm on call and I'm waiting for a baby. And I said, what are you doing here? And he said, well, I'm just getting my charts ready for tomorrow. And I said, well, how often do you do that? He goes, well, you know, most weekends I come in for a couple hours so I can get my charts ready for the next day or the next week. And I thought, you can't even go home at 5 o'clock and put this stuff down on Friday afternoon and leave it alone till Monday because you got a pre-chart or you got a finished chart or I need a note to do on this one. You don't get paid to do that. Hospitals and employers don't pay us to work outside of the office. They expect you to be in the office and get your work done. So go home and really try hard not to do anything at home. Your home time is your family time. Drink fluids throughout the day. And coffee and energy drinks, as you all well know, are diuretics. So you get more dehydrated, just like alcohol. You love drinking it, but you're going to dehydrate. So water is important. And they talk about 3, 4, 8-ounce glasses a day as a minimum to hydrate your body. You know, when you're dehydrated, you eat because your body says, I want something, and your brain says, I want to eat. And other times, you know, you're just putting something else, because when you're dehydrated, your body is talking to you. It's trying to say, give me something. And it makes you tired. So, I mean, and what's our answer? Well, I'll just keep drinking these big, huge gulps of coffee. I recommend you eat something for breakfast because, you know, if you haven't had anything to eat since 8 o'clock at night, and now you're going to work till noon without having anything but a cup of coffee, you know, you're burning batteries, you're burning your energy. So something for breakfast. It doesn't have to be a big deal, but something for breakfast. And then lunch. Eat something for lunch, and then eat something for dinner. I was speaking to one physician who reached me through my website who was really struggling with burnout. And I found out that they work through lunch. They do their morning office. They work through lunch. They get like 10 minutes to grab a bite, and then they start their office again. Well, of course they're burnout. They're never taking a breather to get rest. So you got to do something about lunchtime, whether that's just sitting, taking a power nap, or getting something to eat. Sleep at night, sure, 7 hours is a great average. When I get 7 hours of sleep, continuous sleep, I'm a lot better than when I get a couple hours of broken. Time off. I mean, working every day straight through is physically exhausting. And as they taught, when I heard a surgeon say when I was in residency, a general surgeon resident say, well, you know, who cares? You know, if you don't take call every night, you miss half the good cases. And my corollary to that is, if I don't come in for every delivery every night, I'm going to miss some of my patients. Like, you know, they'll get delivered. There's a doctor there. I have partners who do that. We all take our turn. So not going in every night or each night to take care of every possible scenario is going to be good for your health. And then exercise. For me, I walk distance. I live out in the country. I walk distance. Exercise a couple days a week at least. You get endorphins running. You know, the weather's getting nicer outside. I mean, get outside, go to the gym, whatever. I mean, there's thousands of gyms, you know, that you can go to. So different things. On the emotional side, symptoms that you see is compassion fatigue. You just don't, I can't care about that in person anymore. I don't want to care about that new person, or I don't want to care about this. You get sarcastic and you complain about your patients. You get cynical. It's like, you know, the reason I feel this way is because of my patients. Oh, really? You wanted to be a doctor. You were out there to help people, but you get so burnt down that you can't do that anymore. And that becomes obviously a big problem, because from there, what happens if you don't care about your patients? Something can slip through. So you got to be careful with that. Refill this, you know, give medicine the break, go home, be with your family, be with your kids. Doesn't matter what age they are, be with your spouse. Go out and do something with family. Go out and play golf or do something like that. I mean, whatever sport you love doing. You know, one of my partners loves racing motorcycles. That's her dream of doing things. Well, that's great. Other people have horses, but get out and do something other than think about what you have to do the next week or your patients. Finally, the third bank account is the spiritual, and this is that week-to-week connection with what we went into medicine for. Every interview that we did to get into medical school was, you know, why are you driven to do this? And we probably all said something like, because I want to help people, I want to save people, I want to cure people. But when you get into burnout, and when you get into that point where this bank account is in the zero, it's just a matter of saying to yourself, why am I can't do this. This is killing me. Why? I don't want to do this anymore. You lose that sense of purpose. Combating this, I mean, a lot of people like going on medical missions. Now it's medicine, but it's in a different environment. You take care of people, you know, in South American countries, Central American countries. It's a great thing to do. You get to do medicine without the EMR and without all the complications and people looking over your shoulder, and you cure people and help people. Helping the poor, there's multiple organizations that you can do things for to help people that are indigent. That gives you that good altruistic feeling. Interests outside of medicine, doing charity work. I had a group of people who provides Christmas meals and dinners to people every year. And we all love doing it, we get involved, and it's such a great feeling to get out there and deliver something to people. It brings us that altruistic feeling that it's not necessarily a medical thing. It's in our core that's who we are. There's a lot of ways of managing burnout. One that Dyke Drummond talks about is called the schedule hack. And that's really looking at your schedule and making sure you are in control of the schedule, not somebody else. In my practice, I know how many people I'm willing to see. I don't let anybody add anything out without my permission. I control that schedule. I have, I could put this down on my calendar, what I'm going to be doing. And I also plan date nights with my spouse, or that could be, you know, scheduling, hey, I'm going to be at my kid's soccer game, basketball game, whatever it is. But you got to run your own schedule, because when, you know, we're leaders, we're individuals, we're that Lone Ranger, remember? We got to be in control of our lives. And when we're not, we're just employees being pushed around. And that doesn't go well with doctors. So control your schedule. Focus on what you want also. Here's another one. We all know what we don't want. And we spend a lot of time thinking about, I don't want to do this, and I don't want to do that. I don't want to do this, and I don't. What about focusing on what we really want? What would be a great day for you? What would be a great week for you? What would a great patient look like for you? You could actually write down all the things you want, what your day could look like, and what patients you want, and then start thinking about, well, how do I get there? Do I have patients that suck the life out of me? We all have that. We all have patients that, you know, just drain us, because whether the problems can't be resolved, they're not very compliant, they can be obnoxious, they can be rude, they can be draining, and you got to be able to say, enough. We're not communicating, we're not getting there. You know, I'm not the right doctor for you. And you should be able to say that without anybody being upset about it. Another thing to do, delegate to your staff. I have my staff do a lot of things, and we're a group of 12 clinicians in our OB-GYN group. We have doctors that do everything, and their CMAs are kind of a little bit of administrative. Or we have people like me that say, here, do this, do this, do this, so that I'm not always having to try to keep up with office visits, EMR, and all this other material, the callbacks, the prescriptions and whatnot. You know, you can delegate to your staff. If you're really, really busy and you spend a lot of time trying to document, maybe it's time to ask your organization or your office manager, you know, I want somebody as a recorder, somebody that can walk in the room with me and can document all this stuff, get it in the EMR so that I can read it quickly and sign it or comment on it if I want. Organizations, you're going to push back on this, but you know, there's a way to say, listen, I can be more productive. I can actually see more people if I don't have to go back to my office or sit at the screen while I'm trying to talk to the patient and document all this other stuff. It's an option. How about saying no? You know, we have busy lives, we have busy practices, patients and whatnot, you know, and when you're the nice person in the office, you're the nice, you know, that person knows everything. People are going to come to you and ask you for help. You know, can you do this committee? Can you do this? Can you chair that? Can you this and that? And I just ask you to say, to think about what they're saying and say, I'll get back to you on that. Look at your schedule, look at your life and say, you know, that doesn't fit for me. That doesn't work. And you know what? That's an empowering thing to do, is to say, no, I'm sorry. That doesn't fit on my life. You're going to have to ask somebody else. But our typical self is sure loaded on, loaded on, loaded on. All right, how about I'll do that, but I'm giving this up to take its place. Something else that a lot of people don't do very often is reach over, pat themselves on the back, and say, you know what, you did a great job. Mrs. Jones is going to do so much better because you figured out what was going on, or you got the right medicine, the right treatment, whatever it is. And don't just say, yeah, well, you're expected to do that. No, pat yourself on the back. And I'll tell you, it's the hardest thing for people to do is look in the mirror and say, you rock. You did a great job. That was awesome. And that should spread out to your staff too. I'm very thankful for my staff. They know it. I bring them coffee and treats, and so we work really well as a team. They make my life better, and I help them do their job. So it's a much better situation. Another thing we consider doing is Dyke Drummond, in a course I went through, quadruple aim leadership with him. He talks about doing a squeegee breath. So, you know, a squeegee is that window cleaner thing that we do to use to wipe off the water, or if you have somebody else do it. You know, before you walk in the room, just take a deep breath. And with that breath, just kind of flush out all the other thoughts and the distractions out of your body. And as you're doing that, just breathing that stuff out so that when you walk in to see that patient, you're ready to see them and you're not thinking about the last two patients. And if you walk in with a smile, patient's probably going to respond to that too. These are simple things. There's a lot of things that you can do to manage burnout. These are just some of the simple ones. So I want to move on to the next subject. It's a little more touchy. On the screen you see is Dr. Robert Dykstra. He was an anesthesiologist and ophthalmologist who I've been here since 1997, and he was my ophthalmologist. We lost him in 2010. And I always thought to myself, if he had just had that one conversation with somebody, that he might have felt that somebody else cared about him. And then we lost Dr. Gimlick in 2019. Now, I know both of these physicians probably had major depressive disorders and things were going wrong. So it doesn't just happen. But I was so struck by the loss of these people that were my friends and my physicians in our community, that I knew I had to do something, and I wanted to bring that awareness, because physicians suicide at a rate higher than the general population. I mean, we're we're the superhero, the Lone Ranger, but we suicide at twice the rate of the general population. And I put on my slide here, who else, because in the 24 years I've known I've heard of other probable suicide situations, but I didn't have their names. And sometimes it's, this is something that people don't want to talk about. But I think this is necessary to talk about because there are a lot of physicians that we lose to suicide because nobody wants to talk about it. Physician suicide at the highest rate of any profession. That's an incredibly bad number. One doctor commits suicide every day in the US. The number of doctor suicides is about 28 to 40 per 100,000, and as I said, was twice the general population. It's documented that it's higher than the military top population, and we hear about veteran suicides all the time. Unfortunately, men suicide 4 times more often than women. And interesting enough, anesthesia is at the top in terms of suicide rates in percentage among anesthesiologists, and that rate is followed by surgeons. We know that depression in doctors is a major factor. It's also more common in medical students and residents. And we didn't have this problem most likely before we went into medical school. Now, yes, a lot of people suffer from depression of some degree, but a lot of people go into medical school well and without problems, and they develop depression during their training or their residency and through their practice. Medical students, it's so hard for me to imagine or understand why medical students suicide, because they know that they're the cream of the crop from their college classes. The acceptance rate is 100 people per 3,000 applicants. These are the very bright, the altruistic, but they get lost. Things go wrong, and that's a very scary thought. Unfortunately, hanging and poisoning are among the most common means. And what I found was startling when I was reading through some articles by Dr. Pam WIBLE, who has studied over 1,500 physician suicides, is that when the time gets to be that you decide that this is your last moment, that decision's made within 3 to 5 minutes. It's not a decision that you've made all day. You've just, that you've been depressed, you probably have the means. And once you say, I'm going to do this, within 3 to 5 minutes, this happens. And she's learned this by speaking with people who attempted suicide and did survive. And they basically say, it was a decision I made quickly. Physician burnout may be a gateway problem to suicide. Now, by itself, physician burnout doesn't mean you're going to be suicidal. Otherwise, we'd have half the doctors in the country suiciding, and that's not happening. But that on top of depression or chronic anxiety means that, to me, that physician burnout is a gateway problem. We also know that undiagnosed or undetected depression or anxiety disorders are pre-existing factors. Somebody who has anxiety or depression in a life-altering event occurs, whether that's divorce, loss of loved ones, loss of ability to practice, medically retired, or any other loss of ability to practice, whether that's handicap or, whether there's too many problems with your practice and the hospital says, we don't need you here anymore. Loss of ability to practice takes away the whole reason you went in. We also know substance abuse in the background of what we call moral injury is common. Hopelessness is a huge factor. Hopelessness is when you just don't think you can fix anything. And that people get into a situation where they have learned hopelessness. There's nothing I can do. It's not going to get better. My life's not going to get any better. So why bother? Why am I here? We know in residencies, sometimes medical students, and even in practices, bullying, hazing, sexual harassment, and poor self-care, to name a few, are factors. PTSD from on the job. I mean, if you're a physician and you don't have any malpractice cases throughout your entire career, that's considered extremely lucky. But what happens in a malpractice case? You know, you've done the best you can. You didn't do anything intentionally wrong. You had a lousy outcome or something, you missed something. And you know that attorney is going to tear you apart, that the plaintiff's attorney is going to tear you apart, make you sound bad or look bad. That's what they do as their job. And then you get in the media, you get public shaming. So you look at the news, so and so doctor, removed from practice because of whatever. Or you lose a patient that you really cared about. You did what you could, but you lost them anyway. This all can lead to consideration of suicide. 12 warning signs. They feel like a burden. It feels like they're a burden. They're not really helping. Isolation, increased anxiety, anger, and rage, feel trapped in an unbearable pain, increased substance abuse, looking for access or extreme mood swings, expressing helplessness, sleeping too much or too little, and posting intent or making plans. So what's the real problem? We talk about physician burnout, but many people feel this is a victim blaming term. Victim blaming because doctors are supposed to be resourceful and resilient. And when you're in burnout, you've lost that. So that becomes, well, you've lost that, so you're not, it's your fault. Some people feel that doctors are suffering from moral injury. And if there's a great article by Dr. Simon Talbot and Dr. Wendy Dean about how moral injury can occur in healthcare, which is really about being unable to provide high quality care and healing in the context of medical care. I read an article, this is a good article about why happy doctors commit suicide, because a lot of people, doctors who are lost to suicide, are always the happy, cheery, smiling person. They don't show what's underneath. We know that blaming doctors increases the suicides. Ignoring them increases suicides. Because we don't talk about it, we just brush it under the rug. We also know that suicides are multifactorial, involving a cascade of events. It's not just one event. Just because you get a divorce letter from your spouse's attorney saying you're being sued for divorce or filing for divorce, or you lose that patient, doesn't mean that you're that way. There's a cascade of things. And we know that doctors choose suicide to end their pain. They don't want to die, they just want to end their pain. So we're closing in on the end here. How healthcare systems can help. Addressing 5 physician requests, especially in times of COVID. They were hear me, protect me, prepare me, support me, and honor me. It was found to be very important during the heightened COVID crisis that when leaders visited hospital units, especially those caring for COVID patients, it meant a lot to those people. And when those leaders go, it can't be a grip and grin and how you doing? Hey, great, thanks for your work. No, it really has to be, those leaders show care, whether that's the COO or the CEO or the director of nursing or your medical directors. They need to visit the units and say, thank you so much for doing your work. And how can I help you? What can is there something you need? Yes, they hear a lot of, we need, 25% more staff, or we need more money. There's some things that are harder to provide, obviously, but how can I really help you? And then you can encourage team members to ask for help when you need it. Tell your doctors and your staff, if you need help, please let us know. There are lots of options to do that. There's a lot of support. And then an active peer support program where you're not waiting. Doctors are always treating the ill, but what medicine's trying to get us thinking about is, let's treat before the illness. Let's deal with that problem before that diabetes, that A1C is 11 or 12. Let's work on keeping it normal. And then decreasing barriers to seeking behavior, help-seeking behavior. Don't make it hard to do. It needs to be confidential. Make it easy. Make it easy for people to speak up and say something. And it's really important for executive leaders to embrace the idea that we work in a coal mine, and they need to fix the coal mine and not just the canaries. The canaries are us. We're the canaries in the coal mine. If the coal mine is creating the problems, the dilemma, the stress, it's their responsibility to make this better, so that when you come to work, it's not such a draining emotional event. And you can do that by changing the environment surrounding the clinicians. Opportunities, choices, physician choices in doing things and having a say in things. Fostering a culture of well-being and removing inefficient administrative burdens. I heard recently about, going out and talking to doctors and medical staffs that, then that administrator had to go back and write notes. And wow, it's really not about writing notes. It's about connecting with people and showing that you care. And that really isn't that hard to do, but it has to be genuine. So the last part is a heavy, it is a heavy subject. I made it my goal, whether it's realistic or not, to no physician suicides on my watch. If there's anything I could do to help physicians, and sometimes it's just an ear to talk, because a lot of people just talking gives them an opportunity to download it and what they have on their mind. So I'm here. Parkview has, my parent company has put together something called Vital Work Life with peer coaching, among other things. There are other health systems that do make things available, but we got to use them too. We got to get out there and do that. I put on here a lot of the articles I read and the books I worked with. So there's a lot of good information. And if there's anybody has any questions, this is the end of my presentation. I'll be glad to take those. You can see my email address at the bottom. If you want to email me and communicate that way, I'd love to hear from you. It's just making the connection. That's what I'm here to do now. Thank you.
Thank you, Dr. Drake. And if anyone has a question for Dr. Drake, feel free to unmute yourself and or comment and share with the group, or type it in the chat if you prefer. We'll just take a moment here to see what we can come up with. Thanks again to Dr. Drake. And our next and final webinar is on Friday, April 23rd. We're going to be talking leadership styles with Emily Burmese, who is a local executive coach and consultant. So that will be an interesting chat as well. So Okay, any last call here for questions? Okay, hearing none, I will stop recording, and thank you again, Dr. Drake. If anyone wants to, well, we have Dr. Drake's contact information, and you're always free to reach out to us at the Society for additional member resources or to reach Dr. Drake. And I'll just throw a little teaser out there to stay tuned for next year, because once we are able to gather again, we hope to have some sort of event with the aforementioned Dr. Drummond. So stay tuned for that. Thank you again, Dr. Drake. What a great webinar. And
Thank you.
to everyone who joined us, thanks so much. And I'll sign off now. We'll see you next time.
I know.